And so the buzzwords in cancer care nowadays, besides immunotherapy, which we will get to, are molecular profiling. So Caio, is there a role for molecular profiling for patients with pancreas cancer?
That's an excellent question, and I think it is an unmet need. The problem is that we get them, and many times we do not know what to do with them. In our institution, we routinely perform in patients that have good performance status, are not hospice candidates. We send next-gen sequencing in all of them, and we're doing that prospectively and longitudinally. And most of those reports will come up with the KRAS mutation at codon 12, and we do not have a way to really target RAS today. Having said that, there are a set of patients, maybe about 10% of those patients that have BRCA mutation, that it may be future therapeutic opportunities in ongoing clinical trials that we are going to get to. And outside of the next-gen sequencing, there is some data in the immunotherapy world about the potential role of microsatellite instability that we're also going to get to.
It's not just colon cancer.
It's just not, exactly.
Maybe could I jump in? I know I do this all the time, but part of the barrier, and I know everyone on the table shares this, is adequate tissue.
Yes.
And so often we're making a diagnosis off 2 cells or a couple of atypical cells. And so I don't know if other people, the challenge on molecular profiling is getting enough tissue. And I don't, so we want to do this, and I think one of the problems is we haven't been able to get enough.
Yeah, big education effort around getting core biopsies and not doing the fine needle aspirations, even on endoscopic ultrasound. Do you guys use a lot of that?
Yeah, absolutely. And I think there's been a big change in the field. Well, at least a move in the direction of not living with FNAs, which was the standard paradigm for many years, and trying to do cores, and in particular trying to biopsy metastatic sites, so we have less of an issue in terms of adequate tissue and an ability to profile. But I think the question you raise is really an important practical one, is we know we can do this, and we can do this reproducibly for a lot of patients, but is there added value? And I think we're, to a degree, struggling with this in pancreas cancer, and I think we should maybe get the group's opinion on this, because it's a very topical question and everybody wants it.
So I agree with John that we do need to get more tissue, and it's almost unethical that we keep going forward and putting patients on trials where we don't have any idea, is there a chance that they may benefit? And so it's almost unethical to keep going forward without getting tissue. And so there are issues of whether we should biopsy. I would think we should biopsy. And we were starting actually programs to do rebiopsy. So after a patient progresses, rebiopsying them and trying to figure out how the tumor has changed. We keep hearing in pancreas cancer that it's so heterogeneous. There's so many mutations that are involved. We need to be more dynamic.
So for the average practicing oncologist that's out there, what are they looking for potentially at baseline? It sounds like we're agreeing upon BRCA, and it sounds like we're agreeing upon microsatellite instability, because these patients may be treated differently than a typical patient.
And I think taking a good history, just understanding whether the person or their family is at risk for this disease, so that there may be implications beyond the person themselves, and that's in particular with any germline findings and BRCA, and a recognition that it happens across all subgroups of people with this disease, and it may be anywhere from 5 to 8%, maybe a little bit less, a little higher, but that's potentially very important. We may get some clues in terms of screening for healthy carriers in those families as well.
Yeah, and I think that for patients who have access potentially to clinical trials, having the next-gen sequencing may give them some more options in terms of treatment, and that's when you can talk about maybe something like serial biopsies. And leading into that, clinical trials, George, how do you feel about those for patients with pancreas cancer?
Well, it's obvious that we have more work to do, and we do have a couple standards now, FOLFIRINOX and Abraxane gemcitabine, but we got a lot of work to do, and thankfully there is a trial out there with a lot of interest, the PEG-PH20, the study looking at the hyaluronidase inhibitor. That's going to be an interesting trial. There's some data coming forward that was presented, I think, earlier this month that shows some promising results. So that's one study that I'm looking to see the results. Unfortunately, a lot of trials have fallen to the wayside. So again, we just have a lot of work to do. we've got to get the trials open, we've got to get the trials available, we have to work through the intergroup, and we have to encourage patients to go on study.
You know, I think this group of patients, unlike many of our GI patients, are really interested in trials. They're very high acceptance rate if you've got one, because somehow they know that we're looking for something. I mean, in colon, they may take it or leave it, but don't y'all think this too? You agree?
I think so, but it's a hugely important message, is the need for trials, and this is how we learn quickly in terms of successes and failures. It's mostly been failures to date, but the more people we get on studies, the better that we can improve outcomes. So I think it's an extremely important message. And yes, I think receptivity is there, perhaps more so, particularly even in the second and third line setting when options are becoming more narrow. Patients and families seem very open to studies.
And I can't help but pitch the sort of PanCan-centered studies that are going on. It's really one of the best support groups out there in our space, and they're funding research and they support education for patients around clinical trials. And there is now a nationwide study that couples our discussion of biopsies, molecular profile, treatment assignment for second-line patients. And so we need to get as many patients into that kind of flow as we can.
Yeah, all of these clinical trial matching services, not only through PanCan, but others as well, can help get both doctors and patients access to these studies.
Yeah, a lot of courage by PanCan to take that on. I mean, we've been asking for someone to do that for a long time, and just a lot of courage for them, and kudos to them.
I also like to emphasize that not only on the therapeutic side for the disease itself, but also in the palliative side. You know, in our institution we have plans of open trials for pain control.
Yeah.
You know, what is the role of celiac plexus procedures in pancreatic cancer? Also, you know, getting to gastroparesis, you know, there are opportunities for trials in that setting. And cachexia. Cachexia, you know, was for a period of time, you know, investigated, and some molecules were developed that did not pan out, but it's so prevalent in pancreatic cancer, I think we should rekindle that.
Oh, yes. I mean, we're
that
definitely,
venue.
And just to add to the discussion on clinical trials, this new model of doing clinical trials, and there's a couple of examples of this, Precision Promise in the United States and Precision Panc in UK, which are sort of supported by advocacy organizations in partnership with pharma, in partnership with patients and researchers. And this may prove to be a more efficient model for doing clinical trials quickly. So we'll see if we can move the field forwards with the right resources. And I think recognition from every level, right, in Congress, funding is increased for pancreas cancer, and we know this huge public health challenge is looming with this disease compared to some other malignancies.